Hey guys, it's me, Shauna Butler, host of See You Now. In light of the coronavirus pandemic spreading across the globe, we're listening with new ears and understanding to the episode we released back in January 2020 on lessons we learned from Ebola. This week, we wanted to share it again, highlighting a few key takeaways that are highly relevant to this moment and that offer a detailed account of how clinical teams and health systems safely and successfully care for patients and families, themselves and team members, and our communities. Nurse Sharon Vanairsdale and Dr. Colleen Kraft are both part of the Serious Communicable Diseases Unit at Emory University Hospital in Atlanta, Georgia in the U.S. The lessons they learned as frontline healthcare team members while treating patients with Ebola and the knowledge they continue to share can inform so much of our response in this moment as healthcare workers and as members of a community. As Sharon so exquisitely explains, it takes a village to care for patients with a highly communicable disease. She points to the importance of flattening the hierarchy and valuing the input of every team member and creating a no-blame environment within the team. They call these and treat them as their family rules. They talk about the importance of keeping yourself safe and protected, what personal protective equipment is, and all the tiny details involved in safely donning and doffing it, the exhaustion of working in a high containment setting, the need to take ownership of the environments you're working in so you can care for your patients and keep them safe. They talk about the vital role of communication, not only with their patients, care teams, and institutions, but also with the public and various health agencies. Effective communication for them is a huge part of creating and maintaining the psychological safety of their patients, teams, and systems, and promoting the public's understanding, confidence, and vigilance. The most significant threat to our collective safety, they say, is fear. And as Colleen says in the opening of this show, we can choose to fear or we can choose to care. We expected that 2020, the year of the nurse, would lean more toward a celebration than the call to action it was intended and has turned out to be. But here we are, doing what we do best in the face of difficulty and danger. We are on the front lines, protecting, leading, innovating, and saving lives. To all those on the front line responding to the coronavirus pandemic, remember to look after yourselves and colleagues too. For See You Now, I'm Shauna Butler, and we are with you every step of the way, and we see you now.
See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association and hosted by nurse economist and health tech specialist Shauna Butler.
It takes a village to be able to care for patients with Ebola and other special pathogens. The consequences of not getting it right can be detrimental.
Our favorite phrase came from our chief nursing executive, Susan Grant, who wrote, "We can choose to fear, we can choose to care." And we chose to care.
The Ebola virus causes fear and anxiety wherever it is suspected. It's a deadly disease that knows no borders. Since the 2014 outbreak in West Africa, Ebola has claimed over 11,000 lives. And according to the World Health Organization, Ebola continues to be a public health crisis of international concern. In December of 2019, the FDA approved the highly anticipated first ever Ebola vaccine with plans for it to be available in 2020. In this edition of See You Now, we'll revisit the events of the 2014 outbreak with two of the healthcare professionals who were on the front line of Ebola care. Sharon Vanairsdale and Colleen Kraft are part of the Serious Communicable Diseases Unit at Emory University Hospital in Atlanta, Georgia. And they were part of the team who cared for the first cases of Ebola when they arrived in the U.S. We talk about the challenges that they encountered and the importance of effective communication, what that looks like, and what that sounds like, and the innovations that were born out of the necessity to treat and care for patients with this highly communicable virus while protecting themselves, others in the hospital, and the public. I'm Shauna Butler, and this is See You Now. How about if you guys start by introducing yourselves?
This is Sharon Vanairsdale. I am the program director for Emory's Serious Communicable Diseases Unit. By background, I am an emergency department nurse. I've been a nurse for 16 years now, worked in the emergency department for 11 years, and worked my way into an advanced practice role as a clinical nurse specialist. And I was the clinical nurse specialist when I was asked to join the Serious Communicable Diseases Unit.
I'm Colleen Kraft. I'm an infectious disease physician and medical microbiologist at Emory University Hospital. I was one of the physicians that care for our patients that were repatriated in 2014 with Ebola virus disease, and also one patient with Lassa fever in 2016.
Say the name of the unit again, something that just does not roll off your tongue very easily.
It does not. It's Emory's Serious Communicable Diseases Unit, as evidence how it does not slip off the tongue very easily. Yeah.
Well, let's unpack those. Serious meaning?
Yeah, so these pathogens that we care for, they're serious, so high mortality rates, so serious consequences related to them.
All right, communicable?
So that means that the spread of them, so they can be spread human to human, and we worry about that.
Disease?
Of course, the pathogen itself. So these diseases are serious communicable diseases, kind of defined as those diseases that have a high mortality rate, that there are no proven therapeutics for them, and they often have human-to-human transmission.
All right, unit. That's an interesting thing to think about.
It is, especially when you think of healthcare. You know, we're not your traditional kind of unit or department. This unit, while it does have designated beds there, the staff, the healthcare workers, the nurses, the lab, the technicians, the physicians, we all work in different units across the healthcare system, but we all kind of pull together when we're talking about serious communicable diseases. When we're about to care for patients, it's more of this kind of team mentality versus like just as simply as a physical location.
That is interesting because when we think about units or wards, we think about the physical space, not so much the personnel that comes together. And that's an interesting group of people that you pull together. I'm curious, one of the things that is so important to this is the materials and the environment and working with housekeeping. How are they involved in that team?
Yeah, so, we often talk a lot about the direct care providers. We use critical care nurses in our unit. We have our infectious disease physicians. We have critical care affiliate providers, so our advanced practice providers like nurse practitioners and our PAs. We also have our lab technicians. So those are what we kind of define as our direct care providers. It takes a village to be able to care for patients with Ebola and other special pathogens. So we're talking environmental services, so folks that are kind of behind the scenes, ensuring that all of our waste stream is managed appropriately. We have our infection prevention and control team, so these infection prevention practitioners who are ensuring that we're adhering to infection control principles. We have our facilities management group to ensure that our unit is running as it's supposed to, with our negative air pressure, with our HEPA filtration, with all of those kind of things. Our administrative team to ensure that we are communicating effectively to our patients, to our community, to the healthcare workers in our healthcare system to make sure that we are providing the right information.
So I imagine this isn't something that gets used often, fortunately.
It does not get used often, very fortunately. Our Serious Communicable Diseases Unit started back in 2002 with the understanding that CDC would like their field workers or their laboratory workers to go to a civilian hospital in case they got exposed to something that was a special pathogen or a serious communicable disease. And so that's why it was started. And it has been continually kept open to be activated within 1 hour. To be able to care for patients with these types of pathogens. We do a lot of drills in that area. We do a lot of training in our Serious Communicable Diseases Unit, but we do not, thankfully, have it open very often.
Let's talk about how big of a problem this is. Every year, the World Health Organization puts together this list of top 10 global threats, and there are a lot of public health threats. But what's interesting is that more than half of that list is made up of infectious disease challenges, the ones that we know about, the ones that are emerging, the ones that we haven't heard about. You guys are clinicians on the front lines of treating and researching these highly contagious infections. What are you seeing and what's the scale of this problem?
Yeah, so I think infectious diseases, highly infectious diseases like the ones that we care for, I think that they can be quite scary. I think they're often, we talk a lot about them. While we don't see a lot of it, I think we talk a lot about them because the consequences of not getting it right can be detrimental. So, in this world where you can be almost anywhere within 24 hours, it is a little bit scary that patients may and will present. And so I think informing and educating our frontline providers to be able to quickly identify individuals who may or may not have these pathogens that they know about or that they don't know about. I think that's the other scary thing that we're having to face in healthcare is that we don't always know about the diseases that are out there. Sure, we hear about Ebola a little bit in the news right now with the second largest outbreak occurring in the Democratic Republic of the Congo. We may have heard of SARS back in 2003. Maybe some of us have heard of the Middle Eastern Respiratory Syndrome. But it only takes one patient. It takes one patient to travel, come home, so to speak, like what we saw with severe acute respiratory syndrome, that outbreak that we saw in Toronto in 2003. It took a single traveler returning home from Hong Kong to Toronto that led to over 257 infections and up to 40 deaths. So again, it just takes that one patient. I think that's why we're so vigilant about trying to make sure that we capture it right there at the door. And whether it is something deadly like Ebola or SARS or Middle Eastern Respiratory Syndrome, or if it's, flu, which is just as deadly here in the United States. What if it's the next novel influenza? What about
measles?
Measles, absolutely. Measles is a huge problem right now. I think being able to identify these things right at the door and asking the question, do you have a fever? Or do you have a cough? And some folks even ask, do you have a new rash? Those are things that if we can identify those right away and mask that individual, we have contained and isolated so much of the possible transmission.
Let's pause a moment. As Colleen mentioned, this unit was set up in 2002. It operates kind of like a volunteer fire brigade in that these are healthcare workers who come together on a regularly scheduled basis to rehearse, to drill, and to remain current. When they aren't actively treating a high-threat pathogen, they are back in their home units, but they remain prepared. So in 2014, during the Ebola outbreak, the Serious Communicable Diseases Unit at Emory University Hospital assembled. They were poised and ready to accept and safely treat patients with Ebola in the U.S. Let's talk a little bit about Ebola. How does that present?
Ebola presents very similar to other tropical diseases. So there's a fever, there's anorexia, there's malaise, there's fatigue. And so it's very difficult for individuals to feel that they exactly know what they might have unless they tell you they were just exposed to somebody with Ebola virus disease. That would make that on the list a lot higher. But these types of symptoms happen every day, probably every hour, probably every minute in these types of settings. What I think makes it stand out is really that it's a persistent fever. It doesn't get better, and they just continue to get clinically worse. They end up having hepatitis, and they also end up having profound diarrhea.
And if I were looking at somebody, what would I notice about them?
Well, I think that if you were looking at somebody, you would think that they were having sepsis or just about to be septic. So these are people whose immune system is really revved up, trying to kill the virus that is in them. And they also may have other organs that are shutting down, such as, we had the central nervous system, we had infected, kidney disease, liver disease, blood counts. I really think it's a sepsis-like syndrome once it gets more progressive.
And from onset to as it progresses through, what is that time frame? Is it hours, weeks?
I would say about 5 to 10 days. You kind of know within the first week how serious people are going to be. If you're doing viral loads on them, they may have a lower viral load, and that will signify that their course of illness will not be as difficult. If they have a higher viral load, then it will be, they're about to basically go into a period where their organs may shut down, and you're sort of there to support them through that time. So that's where we really saw the turning point, was within the first week. Could kind of tell which direction people were heading into. The worse that phase was, the worse that their overall infection was going to be.
So let's go back to the summer of 2014, when the Serious Communicable Disease Unit received its first Ebola patient. There was an enormous amount of attention and a lot of concern. So can you talk us through the events of preparing, receiving, and then treating those first patients and their families?
You're absolutely right. I think there was so much hype around it. One, because I think a lot of folks were obviously afraid. And I think when we don't have a lot of information, we don't know a lot about something, we tend to, kind of create stories or create narratives. And so I think that just goes to show the importance of the communication. And I think Emory and I think Atlanta, Georgia Department of Public Health, they all did such a wonderful job communicating as the information was provided. But it was a very chaotic time, and part of my role during that time was to make sure that the healthcare workers who were receiving refresher training and kind of getting back oriented to the unit, that they were not distracted by that, what we called noise, that they had the ability to kind of just focus on what they were going to be doing, about the patients that they were going to be caring for, and about ensuring that they could provide the best patient care while keeping themselves safe. And so that's really where I tried to put my focus. In the meantime, we had a huge team. Like I said, it takes a village. There was a huge team that was in front of the press trying to provide them with the most current and reliable information, while keeping our patients informed, while keeping all of our healthcare workers informed. So there was a lot happening, and a lot going on for sure.
So Colleen, I think I read an interview that you had given where you talked about this experience being so important from a learning experience and a career shaping, that the physician that you were at the beginning and then following the treatment, that those were different people. It sounds like there were a lot of lessons that you guys learned. What were you learning, and how were you building a culture of safety?
So it was a number of things. It was as if we were on 10 learning curves at the same time. I think, we had to learn how to protect our staff from the noise, like Sharon was just talking about, all the pressures around us, how to focus in on our work. But then also we are also just trying to figure out in our unit how to be absolutely safe all the time. And I think for people that haven't worked in the high containment situations, it's exhausting. And so, it's a whole team of people trying to keep each other safe. We were very focused on these family rules that we called them, about how we were to behave and to act together. And, those were life-saving rules to me, but they were things that we held quite seriously. And so anybody could bring up a concern. We had a very flat hierarchy. That was very important to our group during that time, to be able to feel that you were an equal member of the team, that there wasn't somebody that was sort of, I shouldn't say there wasn't anybody in charge, because there were people that had leadership roles. But what happened was that when it came to the care of the patient and the safety of the unit, nobody was different than anybody else.
Yeah, everybody had responsibility.
Right. And so I think that's such a key lesson that I did not think about before, that would be really great in healthcare going forward, is that if we all sort of took ownership in what was happening around us. It's very difficult in our complex healthcare systems, but when in this healthcare situation, we were sort of focused just on one patient usually. And so, we could have all of our effort to that one patient because we weren't caring for a whole ward of patients with Ebola. It was just one or two at a time. And so I just think that was really the point of it, was team safety. And you wanted to be safe because by you being safe, you were keeping others safe, and vice versa. When you kept others safe and when you kept that vigilance going, you were also keeping yourself safe. I think that's missing from so many things today. But that is really, just living through that was really an amazing opportunity among all the other things that we learned even clinically or research-wise.
We do have an awful lot of hierarchy within our health systems, and it can get in the way of safety and better outcomes. So as you're learning this, how are you guys sharing that message and modeling that as an important element and a fundamental foundation for building a culture of safety?
I'll start and Sharon can jump in. I think it's a journey of 1,000 steps. We really try to, because we're doing these quarterly trainings that Sharon is usually leading, I think we're trying to instill these values and keep the values going, even as we all return to our home units. But I think, we're also starting to try to make changes in our own healthcare system. We hired a human factors engineer. Sharon leads a serious communicable diseases steering committee, where we're actually bringing up to healthcare leadership about identify, isolate, and inform individuals that are coming into our healthcare system through various means that may have some sort of communicable disease. And so while I'd love to say that 5 years later we've transformed our healthcare, I still think that we have a long way to go. But I think we know the steps now that we want to take, both clinically and sort of experimentally.
Hey, Colleen, I could not agree more. Change is often very difficult and can be slow, but we're seeing that. And I think it's great to see the healthcare workers who work in our unit pay it forward and see them make changes in their home unit and change how they're doing things in their home unit. I look back at my career as an emergency department nurse, and I think back at, how many times did I start a Foley catheter? How many times did I start an IV? And wish I had learned some of these things that I learned in the patient care room that we learned when caring for patients with Ebola. Had I applied some of those things, maybe I wouldn't have gotten sick as often as I did. Maybe I spread something to one of my other patients because I just did not have this situational awareness about my environment, about my surroundings, with this somewhat of an assumption that my environment is dirty, that I need to take ownership of my environment, cleaning it off, protect myself and protect my patients by wearing appropriate personal protective equipment. But I'd like to think that, we can change healthcare just by doing that.
Can you give us an example of what a near miss? What are some of the near misses? What did you guys specifically learn?
Yeah, I think one of those that we talk about, more broadly in our national trainings, because again, there's learning opportunities for everybody, and it helps describe or explain why we do what we do in relation to our personal protective equipment. But when we first started with our personal protective equipment, we, if you're familiar with what that looks like, we wear...
Let's describe that, because the pictures that we saw, it looked like you guys were getting ready to go to the moon, actually.
Yeah, those would not protect you on the moon, but they do protect you from pathogens like Ebola. So we wear a powered air purifying respirator, often known as the PAPR. So that is... filter on the top. It's got a shroud that covers your entire head and neck area. We wear a coverall that is impervious to fluid and to bodily fluids. We wear 2 sets of gloves, and we wear shoe covers. And then on top of this, we wear an apron to really protect that zipper. And initially, we wore the apron underneath of the PAPR and the shroud. So again, if you kind of think of a layering effect, the shroud of the PAPR laid on top of the apron. But one of our near misses, one thing that we learned and we updated immediately thereafter was when we had a patient who was altered and was able to reach underneath the shroud of the healthcare worker. So again, in this altered state, just kind of reached up when we were turning him and was able to kind of get hold of that coverall. And so we said, going forward, how can we prevent this? And the suggestion was to put the apron on top of that shroud, on top of that PAPR, so that provided an extra layer of protection so the patient could not reach up underneath and grab that coverall. So again, that's one of those real-time changes that we had to make, and was endorsed and suggested by the team.
Yeah, and it's amazing how those small little details, they might sound small, but they make all the difference. One of the things I read about that you guys did on your team is, was it daily huddles or per shift huddle, where you guys talked about the discoveries on an hour-by-hour, shift-by-shift basis, and then had this very rapid learning cycle of where a discovery would then be incorporated into a practice or a protocol. Say more about that. That sounded really interesting.
Yeah, absolutely. So we started we called it like our team huddle or a family huddle. And we had them every morning at 7:15. Whether you worked or not, we wanted you to be on this call because, again, we, in healthcare, and especially caring for patients with Ebola, we want continuity of care. And so this morning huddle allowed us to be able to share what was happening with the patient, what was going to be the clinical plan. And that was really helpful. So if you were not working that day or you weren't working for the next 2 days, you were still informed of what was happening with the patient and what to expect and what changes were being made. Because in addition to, clinical updates, what was happening with the patient, what was viral load, what were we going to do for that day? We were going to try, a therapeutic. We also provided updates to the unit. Are there any changes in how we do things in our protocols? This is that no blame environment where we could identify and address any near misses, which was one of our family rules that Colleen was talking about earlier. In this type of environment where culture safety is so key, we absolutely needed to know if there were any concerns or any near misses that occurred in the unit. And those were, the team was amazing. They reported those immediately so that we could talk about it. I think the healthcare worker liked to talk about it. They needed to talk about it because you get in your brain a little bit and you really start thinking about it. Oh my gosh, did I make a mistake? Did I expose myself? Did I expose others? So it really was important to be able to talk about it right then and there, and then talk about it as a team to say, is there something that we need to be doing differently as a team, as a collective team? What can we do to prevent this from happening in the future? And so we did. We made real-time changes as needed to personal protective equipment, to how we were, perhaps toileting or helping a patient to the restroom, or if the patient wasn't perhaps strong enough to go to the restroom, what considerations how were we going to manage that? And of course, lots of consideration, thoughtful consideration when it came to caring for a very critically ill patient. At the time when we received our third patient, nobody really thought that you would ever intubate somebody and ventilate them and start them in dialysis. This is where these morning huddles, this is where we initiated those conversations to gauge where our staff stood with this. And it was amazing. I was so proud. Again, this, as Colleen has said, this is a life-changing to be part of this team. But nobody hesitated. It was, yes, we can do this. Now let's think of how we can do this. And so that's what the morning huddle allowed us to do.
One of the things that I found really interesting reading through a lot of the materials that you guys provide is the level of preparedness that we have across the globe. But I think specifically you guys are an international resource. Isn't that right?
Through the National Ebola Training and Education Center, we are funded nationally for national preparedness. But I do think we have great relationships with our international colleagues. And so there's a lot of shared information. There's a lot of collaboration because we're all in this together. Even back when we were caring for patients with Ebola, there was a lot of time dedicated to be able to consult and collaborate with other colleagues from across the country and all over the world who are caring for patients with Ebola.
So you guys might not have a lot of patients coming in, but that doesn't mean that there aren't places around the country, around the world, who aren't active. How do you guys help them out?
In whatever way we possibly can. So we're usually very able to take calls and help people with preparation. Quite often, if people are having difficulties or admissions, they will call us for ideas on medical countermeasures or on clinical management. We spent a lot of our time back in 2014, not only with our patients, but on the phone with other sites that had patients at the same time to make sure that the knowledge that we were gaining was being disseminated, since it wasn't as though we could write it up immediately for, all to see. So we did a lot of clinical phone calls. Those were coordinated by CDC.
Colleen, you had mentioned a framework the identify, isolate, and inform. Who does that apply to? I mean, is it just overall? Can you speak to what that paradigm is?
Yes, and I should say that I didn't know that paradigm until we started working with the National Ebola Training and Education Center. So it might have been a paradigm that Sharon was familiar with as an emergency department nurse leader, but I would have to say I only learned this by sort of going back and trying to sort of come with sort of a biopreparedness language that we then went and have trained many healthcare systems in the United States about. So that has to do with the fact that you need to identify somebody that's at risk. You need to isolate them. So kind of what Sharon was saying, if somebody comes in with a cough or fever, we offer them a mask. Just knowing that people who are coughing can spread things that are transmissible. And then also informing the provider or other providers about what the concerns are. So then the natural clinical scenario can be played out, right? So do they need to just be asked a few more questions and then okay, you probably just have influenza, although keep that mask on. Nobody else needs influenza in this healthcare system today. Or is this person just come back from the Hajj in the Middle East and we're worried about MERS, for instance. And so, we just try to kind of do things simply so that they can be done over and over again. This is still a very hard concept for people on the front lines. We have so much cognitive burden as healthcare workers that's really difficult to sort of keep track of all of these things. And so we find that people struggle under, some of the weight of having to remember yet another thing to ask their patient and understand. But those of us that are in preparedness that have seen outbreaks happen and followed them, we really feel strongly about educating everybody that, something that's transmissible in front of you is something to pay attention to.
Sharon, you've been spending a lot of time educating healthcare workers, healthcare systems. So this paradigm, that can be used for anybody, it sounds like. I mean, just the general public would be able to do the identify, isolate, and inform.
Absolutely. Could not agree more. And that's one thing, again, really proud of Georgia Department of Public Health, where it's not just about emergency departments. Every healthcare center, every primary physician, school nurse, small ambulatory care, it doesn't matter where you are. Everybody is a frontline facility. And so, early identification of those individuals. And again, doesn't matter if it's Ebola or the flu. We want to mask whoever it is that comes into that healthcare setting. And I think it's also educating our patients and trying to encourage them to early identify themselves. And so at least at Emory, what we've done and what we've seen happening across the country is some general signage that says, if you have a fever, if you have a cough, please put on a mask. And then, if you've traveled, go see somebody, go see one of our staff members so we can, inquire a little bit more. So we can do a deep dive into what that risk is. Have they traveled to the Democratic Republic of the Congo or to the Middle East, where we know Ebola and MERS are currently outbreaking there. So again, I think it's early identification and empowering and educating our patients and anybody who's working at that front desk to identify, to ask these questions.
The preparedness part, because it seems like our country's ability to respond to these types of pandemics or outbreaks, we might not be as prepared as we'd like to be. So what's your message and how are you guys helping us to get excited and make preparation sexy?
Yeah, it's hard. It's hard to make it sexy. I think one thing that we try to do is learn from previous experiences and events that have occurred across our country and around the world. But ready or not, patients may and will present, and that's what we say. I bet you anything Toronto was not expecting that one patient from Hong Kong who ended up infecting about 250 individuals. Again, so it's time that we are proactive rather than being reactive. And so this is the time that we're able to do that, and taking from these learnings from Ebola and applying it to everyday patient care about masking individuals regardless of their travel, what they have. We want them to be masked, and then doing that deep dive into that travel history. this is just something that I think we have to incorporate into our everyday practice regardless. I mean, this is, with air travel the way it is, we don't have a choice to be ready. It's a must do. And as a former emergency department nurse, I think about all of the things that I had to learn, all of the things that I had to do for my annual competency. But what about protecting myself, my community, and other patients by having to put on and take off personal protective equipment that would protect all of us? So again, I think it's just kind of reframing things and rethinking and just slowly but surely changing that paradigm to say that this is just a must-do.
We've talked about the epidemiology and how rapidly and unexpectedly these pathogens spread. We talked about building a culture of safety within the unit, not only where the health and well-being of patients and clinicians are top of mind, but also building psychological safety, a no-blame environment where all members of the healthcare team are encouraged and feel safe to report near misses immediately. All of these are innovations in the healthcare system, and they are critical to achieving desired outcomes. When it comes to deadly, contagious disease outbreaks like Ebola, the terms quarantine and isolation take on fresh relevance and urgency. We understand the science and the operational systems that need to be in place. But what happens when fear and anxiety, the public's fear, and the personal and institutional anxiety enter the equation? You have to remember, until August of 2014, Ebola in the U.S. was an abstract idea. The general public and healthcare teams in the U.S. had only seen Ebola in news stories. But when Dr. Ken Brantley, the first person infected with Ebola on U.S. soil, arrived at Emory University Hospital, it became real. Emotions and tensions were palpable. There's a real heavy focus on the pathogen, the diagnostic, the treatment. I mean, there's some spectacular science and technology with all of this. But as a nation or as an individual or as a health team, these outbreaks and pathogens, they create a lot of anxiety and a lot of fear, some even bordering on panic. So how do you speak to the human elements of being a team or a caregiver? How do we manage that part and still deliver on the care that we need to?
Yeah, so I think it's about effective communication. When you have information, how are we sharing that information? And even that sometimes isn't adequate. Some people, even when you have as much information that you possibly have and you're sharing that, it still isn't enough and people still are scared. And that was even with Ebola. We would talk about what we were doing, how we're keeping our community safe. And regardless of the science, so we know how Ebola is transmitted. We know that individuals, due to the viral load, if they're not symptomatic, then it's not transmissible. So again, I think it's going back to the science, and I think it's up to us as healthcare workers to keep developing what that science is. We need to develop that new knowledge when we know more about these pathogens. Again, I think we learned so much with Ebola. I think it's on us to go ahead and continue that knowledge and to translate that knowledge to the bedside.
Yeah, you guys really were placed in a very high-profile media event. I remember seeing the pictures of the news reporters just lined along the sidewalk at the entrance of the hospital. So it probably gave you also unexpected learning and education on how to be a source for the media. So how did you use this as a tool to develop public education tools and public policy informing? There was just an awful lot of opportunities. What have you guys learned from the communication standpoint?
Yeah, I think that, again, it's that effective and efficient communication, ensuring that everybody, especially that collaborative communication that happened between Georgia Department of Public Health and Emory University. And I think that is also a little bit of a learning curve for healthcare workers. I don't know about you. I had never received media training. I did not go into the nursing field to think that I was going to get in front of somebody with a microphone. Like, this is all very new to me. But again, I think it's the system kind of stepping up and knowing where to put resources when they were needed. So providing staff with media training. I will say that a lot of the media training initially went to our physicians. And I really appreciated that they were the ones that were able to get in front of the camera, because honestly, the nurses were spending majority of their time at the bedside. And I think having any media kind of in their face that would change the focus and allow for perhaps some noise, from external noise, to interrupt what they were doing. But I think it's having an effective communication strategy in alignment with and making sure that the information that's going out is consistent with other agencies. But people just want to be kept informed. It's kind of like when you're waiting in traffic and you have no idea why there's traffic. It's like, why am I stopped? If somebody were just to tell me, if Waze just popped up and said, oh, there's an accident, at least I know, right? Like, at least I know a little bit here. So I'm not creating my own story and causing more frustration. So I think that that's really important. Colleen, is there anything you would add to that?
No, I think what you said is exactly what happened. So I think, we are continually pushing ourselves so that everybody can be a spokesperson. And I think that will be more apparent in the future as we sort of organize around the communications aspect. I think it was sort of a default to use the physicians as communicators, but I think there is a lot that could be learned from the experience of the nurses and others that are in our unit. And we want to make sure that everybody gets sort of highlighted and their perspective is shared for the reasons that Sharon mentioned.
I think one of my favorite visuals and communications was when Dr. Ken Brantley was leaving the unit and the cheer line that he got to go through, and just everybody celebrating the success, because there were so many unknowns. But I love that image. And then on the 5-year anniversary, bringing people together. And again, spectacular science, spectacular research and technology. But at the core of this, I think it was one of your nurses, Jill Morgan, who was talking about that the goal there really was, we were going to see you guys walk out. And I just cannot imagine how gratifying that must have been for everybody to see that shared success. I'd love for you guys to chime in on that, because it sure looked happy from my end.
Oh, yeah,
we call it the Hugathon.
It was the Hugathon. It was a moment for everybody to celebrate. And I think that those hugs were genuinely just so proud of what had been accomplished, that we were just so happy that Kent was recovered, that he was being discharged. And I think it also is a sign to show the world that he was safe to go out. But I think not only the relationship with Kent, our patient, but with also Amber, his wife, you become incredibly close to the family as well. And so I think having that moment, and I think having that 5-year, the opportunity to come back and revisit, because these bonds are lifelong, not only for the healthcare workers working together, but with our patients. And so again, I think that it was an amazing experience.
Yeah, you mentioned his wife. What technologies were you guys using he's in isolation, he's sick. Family is worried sick as well. How did you guys keep them connected so that emotional support, giving him the support that he needed so that he could physically heal? How did you guys manage that?
Yeah, we were really proud of the fact that we were able to keep his family close by in our unit, in a waiting area in the unit, so that they could always be there. And we also allowed limited visitation. And I say that with the caveat that it was never in the patient care room. Our unit was set up with a window to allow the family, with very specific rules, to be able to see their loved one in the patient room. So again, not in the patient room, outside the patient room, but in person. So yes, we do have technology, using iPads and those type devices. But I have to say that there was just probably something about having that, just the window separation. It just made it so much more real. They were right there. They could see their family member again, not in the patient room, not touching the patient, but just being able to visually see them, not through an iPad, I think was pretty remarkable.
Yeah, there was also a lot of fear and panic around the spread. And how did you guys manage to contain that, or just hold it and not let it take hold of you? And the reason I ask that is I think so much about my early experience with the AIDS virus. And at that point in time, when it first started rolling into the departments that I worked in, we had no idea what it was. But what we saw was a lot of fear, a lot of concern, and not our finest moment in how we took care of each other. And so I'm wondering what you guys have learned from that, because they're always, Colleen, you can speak to this, There are going to be emerging viruses that we have yet to meet. And yet we're going to have the exact same set of experiences as care professionals, as communities, as just individuals. How do we work through that fear?
Yeah, so our favorite phrase came from our chief nursing executive at the time, Susan Grant, who wrote an op-ed that's basically said, we can choose to fear, we can choose to care. And we chose to care. And I think that continues to undermine everything we do. Like Sharon said earlier, patients are going to present. So we can either stick our head in the sand like an ostrich and pretend it's not going to happen to us and be in denial, or we can be ready and see that the benefits of having these types of teams and skills in a healthcare system helps us in a lot of other ways. It's taking care of the patient in front of you in a really good way. One of our main concerns is these people being isolated and not getting the right care. So they come in with some other terrible thing happening to them, like a stroke or a heart attack. And because we're so fearful, we actually allow harm to come to them because we are fearful of their travel history or something. And so we're really trying to create that balance of equipping ourselves to be ready for these types of conundrums, and then, doing the right thing in the moment, having a team that's a good resource for the moment.
Well, I can't thank you guys enough for the work that you're doing and the education and the research that you're providing and the brightness. It's just a huge community lift when hearing your stories and the things that you've been learning and sharing. So thank you again for joining us today. It's been an honor and a delight.
And thank you so much. I really appreciate you helping us share the story and getting the information out. So thank you.
Sharon Vanairsdale is a clinical nurse specialist and the program director for Emory's Serious Communicable Diseases Unit. Colleen Kraft is an infectious disease physician and a medical microbiologist at Emory University Hospital. They are part of the specially trained team who cared for the first cases of Ebola at Emory's high-level biocontainment unit when the cases arrived in the U.S. in 2014. Together, they are part of Emory's team of researchers and infectious disease experts who are working to find game-changing therapies for this disease, translating the learnings from 2014 to everyday patient care and creating innovative protocols of care that are now the standard when caring for patients with deadly infections. We caught up with Colleen while she was on rounds at the hospital, and we spoke to Sharon from the WABE studios in Atlanta, Georgia. Special thanks to Jill Wu and the Emory University Communications team for helping to facilitate this conversation. I'm Shauna Butler, and this is See You Now.
See You Now is created in collaboration with Johnson & Johnson and the American Nurses Association. Johnson & Johnson is proud to power up nurse-led innovation that is transforming health outcomes through skill building, leadership development, and more. The American Nurses Association ignites and celebrates nurse-led innovation to redefine quality nursing and advance healthcare for all. You can help millions of people find this podcast by downloading and subscribing to See You Now wherever you get podcasts. To learn more about See You Now, Johnson & Johnson, and the American Nurses Association, visit seeyounowpodcast.com.